Harry, I have a question. This is always a matter of big debate in my center. What about if there's somebody that's 50 years old?
Yeah. Right. So again, not in the study, but now in the label. And that is
secondary AML in a 50-year-old.
Secondary AML. And,
55, 59, right?
Okay, 59 or 60 like me now. So just to bring everything up to date, okay, why was it approved? Higher CR rates with CPX-351. It met the primary endpoint of overall survival, right? 9.6 months with CPX-351 versus 6 months with 7 and 3. Lower induction mortality at 30 days, at 60 days. Patients went on to transplant, had better outcomes after CPX-351 than after 7 and 3. We haven't seen all the subset data. We've seen for treatment-related AML in the older patients, they also enjoyed a survival benefit. We haven't seen the data specifically on the molecularly or cytogenetically defined or the molecularly defined.
Right,
so
right.
We don't know that it's better, but we're hoping it's not worse. But the question you're asking me, would you use it in a younger patient with those characteristics?
Because the patients on that trial, right, were not 59.
No, and they were patients fit for chemo, but ones that you would feel comfortable giving 7 and 3 to. At this meeting, there was some data presented from Japan showing that incorporating intermediate dose cytarabine into induction regimens may increase CR rates, not overall survival, but improved disease-free survival. So that's the trouble. In NCCN guidelines, we could use more intensive regimens with intermediate dose Ara-C. The EORTC also published data for patients under 45, maybe a benefit of a regimen including higher dose of Ara-C. And I know at MD Anderson, that is your typical treatment, is to use high-dose Ara-C.
Yeah. That's correct.
So I guess the question is, I think my answer would be that is an option, CPX-351, but I know that many would say that they don't know that it's better than intensifying with chemotherapy, and I think those studies need to be done.
Yeah, I would absolutely say the same. I would say biologically, it's absolutely plausible you should see the same benefit. The difference is you can give more intensive regimens comfortably in younger patients, and they may make up the difference. And then it gets to the question that you mentioned before, which is there a cost benefit to using one approach versus another?
I'm just going to play devil's advocate. So there is that landmark analysis showing that patients on the original phase 3 trial that got CPX versus 7 and 3, when they went to transplant, that there seemed to be a wide differential between how the patients getting CPX who went to transplant did than those that got 7 and 3 and had a CR, went to transplant and did. So the feelings from some individuals is that the CPX, because it's a more potent agent going into the bone marrow, might be inducing what we say a deeper response or theoretically a more MRD negative response, so that patients are going into transplant with lower disease burden. Now you can accomplish the same thing, possibly with an intensified, cytarabine or daunorubicin, but is there something about that particular, as you said, molar ratio or liposomal formulation that gets a better, deeper response? What do you, I'm just throwing it out there as a possibility.
I think that's a very important point. If your goal for these, especially younger patients, to get them to transplant, we have the data from the phase 3 study that they may truly do better and not know why. We need the MRD data. I think you can make a very strong argument for giving CPX-351 to that patient at this point, even though they're younger, and it's in the label.
We just don't have the exact
we don't have the exact data. The elephant in this room is the cost, right? Yeah. But we have to be very, very careful about that cost, because as I heard you say recently, you have to consider the entire cost. And if a patient doesn't respond and they're in the hospital with persistent cytopenias, or the cost to human existence if they never make it to transplant, that is a greater cost. I didn't say it as elegantly as you said it.
Well, yeah, I think that, so say it costs $50,000 to give this drug versus, $8,000. So there's, like a $42,000 difference. But if this person with the $42,000 drug can get into CR, and there was a difference in CR, and this person can go into transplant and they can save their life, in the long run, if that person relapsed again, had to have salvage chemo, then had to have a salvage transplant, what's the cost benefit? And what about that individual patient being able to go straight to a transplant,
And on top of that, this age thing, okay, so you challenged me, 59, 58. The data from the EORTC and the study here with intermediate or high dose Ara-C only showed a benefit in the younger of the young. So
Right.
under 45, almost an
Yeah.
AYA population where you can intensify therapy. So I think, you can make a very strong argument for using the drug in a labeled indication regardless of the age of the patient.
Okay.
How do, I don't want,
One
how
thing
do
we
other
haven't
people
talked
use
about
it?
at all is toxicity. One of the major benefits of this drug was that not so much that you saw a higher CR rate, but that the treatment-related mortalities were lower, largely because of lower rates of lethal complications. And in some ways, that
From
was because
leukemia, specifically.
leukemia wasn't growing
Progression,
back
yeah.
quickly after CR. If you looked at the rates of infections during aplasia, they were actually higher in the CPX arm, and the duration of nadirs were longer, and yet other toxicities were less. These patients seem to, at least in our limited experience with it, get less mucositis. They don't lose their hair. It's a different pattern of toxicity that we see.
Well, and I think that goes with this liposomal delivery of drugs in general. I think that, we know that liposomal amphotericin is less nephrotoxic than generally than the
Right,
straight. So, of course, the mucositis and the hair would be important, but can we then have less cardiotoxicity because this is liposomally encapsulated? That would be a great benefit. And it goes back to the concept of intensifying the free drugs. Well, can we intensify these further? There was a limit because at the moment you had to consider the 1-to-1 equivalent of the anthracycline, and you had that limit, et cetera. But do you have the same limits when you have this formulation of an anthracycline?
Well, I want to be
And
very clear on that. So I was an investigator on that trial, and it was assumed, and it continues to be assumed by the FDA and the label, that in the absence of data, it's a 1-to-1 equivalence in terms of cardiotoxicity. You're right. We really don't know. And in the study, remember, it was treatment related, and we had many patients who received anthracyclines, and they could only receive a certain amount. What I would say about the cardiotoxicity is that if you look at the adverse events, it was a similar rate of non-conduction cardiotoxicity in both 7 and 3 and CPX-351. It was 20%. But that's much higher than what you'd expect right from an anthracycline induced. And I think what that really was sepsis and transient cardiomyopathy.
Right.
Which evens out over time.
It does, and let's face it, the incidence of cardiotoxicity with 7 and 3 in someone who hasn't had an anthracycline is only like 1%. So I think it's going to be hard to show that benefit, but I will say this, when you compare the cumulative dose of CPX-351, the cumulative daunorubicin dose, with a full course of CPX-351 versus 7 and 3 followed by 5 and 2, you're actually getting less anthracycline with CPX-351. So if you do believe they're equivalent, it may be a way of getting more of the drug or getting the drug into
getting
patients.
less toxicity at least because of that.
At least there.
And then the person's going to transplant.
Right,
and
which is important.
we certainly don't want to have high levels of cardiotoxicity going into transplant.